A very good evening. Hi guys, I hope you're all doing well. So, am I audible and visible to you all? Right. So, welcome to the platform of eGurukul and DBMCI. So, today I'm going to discuss a very important topic of for FMG, that is antepartum hemorrhage, because we got this question last year in 2020. We got this question, so that's the reason why I choose this topic for you all. So we'll learn the topic as well as we'll do the MCQs in that topic. So how is your preparation going on? How are you learning obstetrics and gynecology? I'm going to discuss a very important topic. Right. So this is the question which we got in the exam. So we'll come to this question once I explain everything about the antepartum hemorrhage. So we will learn about antepartum hemorrhage. We'll learn about types of antepartum hemorrhage. We'll learn how to manage them, and then we will again solve MCQs on it. So that will be the session. Okay. So I hope you're all ready. So this was the question which has come to us in the exam. A 36 weeks pregnant patient came with the complaints of bleeding per vaginum associated with pain. So third trimester bleeding, the fetal heart rate is absent and uterus is tender. What is the diagnosis and management? So as of now, we'll not completely discuss this. We'll come back to this question and we will discuss the question again. Okay? Right. So what do you mean by antepartum hemorrhage? When do you call antepartum hemorrhage? Yes. So antepartum hemorrhage is bleeding from or into the genital tract after the fetal viability and up to delivery. So antepartum hemorrhage is defined as bleeding from or into the genital tract after fetal viability and up to delivery. Right? Very good evening, Alphas. Hello, Krishna Chaitanya. So, rapid revision of my notes video, is it enough for FMG? Yes, that's fair enough, good enough. But along with that, try to solve more and more MCQs. So, I try to cover all the topics in the rapid revision. But yes, it is it is concise, right? So there was one question in the exam, that when do you call antepartum hemorrhage? So antepartum hemorrhage is bleeding after the period of viability. Now, period of viability is again a big controversy always, because according to Indian Academy of Pediatrics, period of viability is 24 weeks. So bleeding from or into the genital tract after 24 weeks but before delivery. According to Indian Medical Association, it is after 28 weeks. So can you name any causes for antepartum hemorrhage, guys? I want you people to answer any causes which you know which can lead to antepartum hemorrhage. So abruption, placenta previa, Vasa previa, circumvallate placenta. So the causes are placenta previa, abruptio, Vasa previa, circumvallate placenta. Very good, Avantika, excellent. And local causes like polyps, carcinoma cervix, varicose veins, trauma. And last we have unclassified or indeterminate. Last we have unclassified or indeterminate. So these are all the different causes which we have for abrupt antepartum hemorrhage. Among these, the most common causes which can lead to antepartum hemorrhage are placenta previa and abruption. Placenta previa and abruption. So this is a picture of Vasa previa, guys. So in Vasa previa, it is the fetal vessels with membranes lying over the internal os. It is the fetal vessels and membranes which are lying over the internal os. So Vasa previa may obviously when fetal vessels and membranes are over the internal os, there is high risk of bleeding or fetal hemorrhage whenever the internal os opens. So that is why Vasa previa is very dangerous. Now what all placentas can lead to Vasa previa? So Vasa previa can occur when we have velamentous placenta, when we have abrupt placentas puri succenturate, placenta bilobata, right? So when you have any of these presentations, there is always high risk of Vasa previa. So in Vasa previa, if the cervix opens, it will be the fetal hemorrhage. And baby can die in minutes, guys. Baby can die in minutes, right? So can you tell me? So diagnosis is by Doppler, TVS, transvaginal sonography with Doppler. And you should go for elective LSCS. You should never allow her to go for vaginal delivery, right? There was one test earlier days after the bleeding has happened and death of the baby. You want to differentiate whether it is fetal blood or maternal blood. So what is the test which can differentiate between the fetal blood and maternal blood? I want you people to answer this question. What is the test which can differentiate between the fetal blood and maternal blood? Okay, so the test which can differentiate between the fetal and maternal blood is called as qualitative test to differentiate feto-maternal hemorrhage, and this is nothing but APT test. It is also called as Singer's alkaline denaturation test. Singer's alkaline denaturation test. Right? It is not Clare-Bedke test. Clare-Bedke test is a quantitative test for to determine the feto-maternal hemorrhage. So Clare-Bedke test is a quantitative test to determine feto-maternal hemorrhage. Okay. So I hope you are clear with this test names. So qualitative test is APT or Singer's alkaline, where we use the reagent of potassium hydroxide or sodium hydroxide, whereas Clare-Bedke test is a quantitative test which we use in RH isoimmunization. So there we use citric acid, so we also call it as acid elution test. Okay. Very good evening, Achin. So that's about the Vasa Previa. Now coming to the abruption. So in your time, there were many questions on abruption. So we always have to let us understand about abruption and then we'll answer about abruption. Normally, placenta should get separated in which stage, guys? Normally, placenta should get separated in which stage? So we all know that normally placenta will get separated in the third stage, right? But here, there is premature separation of a normally situated placenta. There is premature separation of normally situated placenta. So as the placenta is separated before third stage, Bichara uterus is thinking ki, oh, placenta is separated. Let me expel everything. So uterus goes on contracting. Continuous contraction. Now as uterus is continuously contracting, how will be the blood supply to the fetus? Will there be good blood supply to the fetus? So blood supply to the fetus will be compromised or will it be normal? So blood supply to the fetus will be compromised or decreased. Right? So because the blood supply to the fetus decreases due to continuous contractions, the baby will have fetal distress. And as the placenta is separating, there will be bleeding. As the placenta is separating, there will be bleeding. So they'll have painful vaginal bleeding. They'll have painful vaginal bleeding. And as there is fetal distress and due to contractions, mother cannot perceive the movements. So mother will present you with decreased fetal movements. Okay. So this is main scenario what happens in abruption. Now can I wait and watch in abruption? What happens if I wait and watch? If you wait and watch, the placenta goes on separating and the blood flow to the fetus will go on compromising. So never wait and watch in abruption. You have to always deliver the baby in the abruption immediately, irrespective of the gestational age. Otherwise, placenta will separate and baby will go into hypoxia and death. So you have to act quick. As uterus is contracting to expel the placenta and products of conception, it is painful bleeding. It is painful bleeding, right? Mode of delivery, again, all of you will answer that cesarean. No. What happens here is, as uterus is contracting, so uterus is in Josh to push everything outside. So when uterus is in Josh, you have to motivate that, right? So you will continue vaginal delivery unless there is fetal distress. Only if you have fetal distress, you have to go for cesarean section. Otherwise, you'll always go for vaginal delivery. So this is the brief about the abruption, guys. I hope you all understood about the abruption. So let's quickly go through the abruption so that we can solve the MCQs. So risk factors are increased maternal age and parity, hypertension, PROM, drug abuse, sudden uterine decompression, trauma and folic acid deficiency. So trauma, hypertension, drug abuse, PROM are some things which you have to remember. We have three varieties of abruption. When the placenta is separating and the blood comes out, it's called revealed. When placenta is separated and the blood gets accumulated behind the placenta, you call it as concealed. And you also have mixed where you have revealed plus concealed. Concealed is the most dangerous. Concealed is the most dangerous. Concealed is the most dangerous, right? So in revealed, the pallor will be with proportion to the bleeding. Concealed में pallor will be out of proportion to bleeding because there is no bleeding but severe pallor. And uterus will be more than period of amenorrhea in the concealed. Mixed में it's a combination, right? So clinical presentation. So will it be painful bleeding or painless bleeding, guys? Will it be painful bleeding or painless bleeding? So they will present you with painful vaginal bleeding, decrease to absent fetal movements, decrease to absent fetal movements. So on examination, patient can be in shock. Uterus will be hypertonous, that is contracting more. Tender. And you'll have fetal distress to fetal death. You can have fetal distress to fetal death. So FHR can be absent also. You can do PV here, guys. There is no contraindication for PV in abruption. When you do PV, you can do artificial rupture of membranes. When you do artificial rupture of membranes in abruption, what will be the color of liquor, guys? So what will be the color of liquor? So you will see blood stain liquor. You will see blood stain liquor. So investigation of choice is USG, where you will see retroplacental clot. Very good, excellent, Gunam and Alex, correct. So you'll see blood stain liquor. Next, coming to the grading. So you also have a grading for abruption, that's called page grading, guys. So page grading is, it starts from grade 0. So grade 0 is retroplacental clot, or retrospective diagnosis. Grade 1 is mild bleeding, uterus hypertonous and tender, but no fetal distress here. So only symptoms. But no fetal distress. Grade 2 is fetal distress to fetal death. Grade 3, maternal, DIC, shock and death. See, understand, guys. First and foremost, the staging is starting from grade 0. Many students think that it is starting from grade 1, but it is starting from grade 0. So grade 0, बाद में you find out that, oh, she had a abruption. Grade 1, only symptoms. Grade 2, bacha gone. Grade 3, mother gone. So this is called page classification for the abruption. Now coming to the last, management of an abruption. So how do you manage a case of abruption? So there is a rule in abruption that is called as Pritchard's rule. We follow something called as Pritchard's rule. So please remember, in abruption, never wait and watch. So don't give tocolysis or wait and watch. Irrespective of the gestation, you have to terminate the pregnancy. Never wait and watch. You have to maintain the hematocrit more than 30% and you have to maintain the urine output more than 30 ml per hour. Now regarding the mode of delivery, you have to check the fetal status first. This is a very, very important table, guys. I want you to understand this table perfectly. Okay. So you have to check the fetal status. If fetus is alive, and if there is no fetal distress, then you will try to conduct vaginal delivery by induction of labor. So you're trying vaginal delivery. If fetus is alive but fetal distress is present, then you have to go for LSCS. If fetal distress is positive, then you have to go for LSCS. If fetus is dead, then you have to check the maternal status. So in maternal status, if DIC is present, correct DIC. If no DIC, then you can go for vaginal delivery by induction of labor. So basically what I'm trying to tell you is when you have a patient with abruption, you will go for vaginal delivery by induction of labor. Only when there is fetal distress, only then you have to go for LSCS. Otherwise, you can go for vaginal delivery. Otherwise, you'll go for vaginal delivery, right? So this is in short about abruption. So abruption is premature separation of placenta. You'll have painful vaginal bleeding. You have three varieties in abruption, that is revealed, concealed and mixed. There is increased risk of fetal distress to fetal death. Investigation of choice is USG. Always terminate, never wait and watch. Hematocrit should be maintained more than 30%. Urine output should be more than 30 ml per hour. You conduct vaginal delivery only when baby is showing fetal distress, you'll go for cesarean. Otherwise, you'll always conduct vaginal delivery for abruption. So let us see one question, guys. A primigravida presents to the casualty at 35 weeks of gestation. With acute pain abdomen for 2 hours. Vaginal bleeding. So it is painful bleeding. And there is decreased fetal movements. Obviously, fetal movements will decrease because when there is continuous contraction, you cannot perceive the movements. She should be managed by. Good evening, Kaustubh. Very good, Kaustubh. Right, so most of you have answered A, but actually the answer is B, guys. So I already told you just now ki only when will you conduct cesarean? You'll conduct cesarean only. You first initially answered B and then changed it to A. B is the correct answer, guys. What did I tell? When will we do cesarean? Only when they have fetal distress. Then only you'll go for cesarean. Did I mention here if there is fetal distress? Obviously, they'll have decreased decreased fetal movements. Decreased fetal movement is obvious. Why? Because there is continuous contractions. So continuous contractions will decrease the fetal movements. But I didn't mention there is fetal distress and it is just 2 hours. Why do you want to go for cesarean? Decreased fetal movements. When patient is in labor, can she perceive fetal movements? जब दर्द आ रहा है तो उसको पेन पता, उसको बच्चे का मूवमेंट पता चलेगा क्या? ऑब्वियसली नहीं, right? So when she is getting contractions, she cannot perceive the movement. So there will be decreased fetal movements. So how should you manage her? You have to manage her by immediate induction of labor. Reduce fetal movements does not mean she's having fetal distress. Unless until they mention fetal distress, you should not consider it as distress. Okay? So all of you understood that it is just to confuse you, to misguide the answer. So I hope you all understood. She's having reduced fetal movements because she's not able to perceive the movements as there are continuous contractions. Okay, does anybody know what is the name of this? So this is called covular uterus. This is called covular uterus. So covular uterus is seen in covular uterus is seen in covular uterus is seen in concealed abruption. So in concealed abruption, you will observe the covular uterus. In concealed abruption, you will observe the covular uterus, right? Now we'll discuss about placenta previa. So I hope you're all clear with abruption. Now we will discuss about placenta previa. So first let's understand about placenta previa and then see about the placenta previa. So a patient comes to you at around 8 weeks with minimal bleeding. What will be your suggestion to her? So yes, Alex, if patient has come to you telling that doctor, I have minimal bleeding at around 8 weeks, what will be your suggestion to her? So at around 8 weeks, if they come to you with minimal bleeding, you can reassure them because it can be placental sign also. Right. So it can be threatened abortion or it can be placental sign or it can be placenta previa. So rest and you would like to do a USG. Right? Very good. So when you do a USG, you're seeing the placenta near the internal os. What will be the counseling which you will do for her? Will you jump and tell, oh my God, your placenta is down, you will bleed to death and all? So obviously, no, what will you suggest her? You can wait and watch. You can wait and watch. Why? Because with the growing uterus, the placenta can also move up. So in placenta previa, when you diagnose when you diagnose it in the first trimester, you can wait and watch. Why? Because with the growing uterus, the placenta can also come up. Okay? Yes, excellent. So I was waiting on this patient. I repeated the scan at 20 weeks. It's still low line. She came with again bleeding. I told her bed rest. Take some rest, right? One day at around 32 weeks, she has come to you with telling that, doctor, I was sleeping and when I got up, I saw I was in a pool of blood. Not literally pool of blood, but yes, more blood, right? So if what will you manage now? How will you manage now? So when she has come to you at 32 weeks and she's telling the doctor, when I got up, I saw it, I was in a pool of blood. How will you manage her now? I don't want to terminate the pregnancy because she is 32 weeks only. So I will again ask her to give bed rest. But now the bed rest will be in hospital. not in the home, and that is called expectant management of placenta previa, that is McAfee and Johnson's regimen. Okay. So placenta previa is characterized by all except placenta previa is characterized by all except. So I told you she was bleeding even in the night, and when she got up she saw. So it is painless bleeding. When she was sleeping she bled. So there is no cause on this, it's causeless bleeding. She had episodes from the first trimester, so it is a recurrent bleeding. Each episode of bleeding is called as warning hemorrhage, guys. It presents after first trimester is wrong. It can present in the first trimester itself. So it's characterized by all except presence after first trimester. Except presence after first trimester. Very good. So placenta previa is placenta located over or near the internal os. According to the recent Williams, he is like internal os is so small, and that how can you tell marginal, partial, total? So he told there's only two classification. According to recent, there's only two classification, guys. One is low lying, another is placenta previa. He doesn't divide it into marginal, total, partial and all. He just tells all those together, you can call it as placenta previa. So low lying is placenta within 2 centimeters from the internal os. So low lying is placenta within 2 centimeters from the internal os. Type 2, this is the older classification. Type 2 is marginal, placenta touching the internal os. You have 2A, which is anterior, 2B, which is posterior. 2B is also called as dangerous placenta previa. So when it is covering the internal os partially, you call it as type 3 or partial placenta previa. Type 4 is total placenta previa. Right? So the risk factors: increasing age and parity, past history, previous cesarean section has probability of previa 4 times greater than patients without scar. Multiple pregnancy, prematurity, smoking and accreta in the current pregnancy. So these are the risk factors. Very good evening, Nirvikar. So I think as you are in the second year, please try to build up more sub. You should know better about the pathology, pharmacology. So pathology ko I think you should digest it more better, so that your basics, when they are perfect, you can do well in your clinical subjects. So go well with pathology, revise well with the pharmacology, all classifications try to write in one book, and every day night try to revise it, so that by the time you come to your internship, you will remember all the classifications like awesome. Okay. And try to solve the MCQs of both first year and second year now in the second prof, so that you will be ready when you come to your internship. You can concentrate more on the clinical subjects. This is a simple funda which you can apply. So as you have finished anatomy, physiology and biochemistry, try solving MCQs of anat, physio and biochem, so that you are perfect with those subjects. Simultaneously, you start solving the subject MCQs of second year also, so that you will be, by the time you come for your final year, you will be concentrating more on your final year subjects. Okay. Right. So now the clinical presentation and management of placenta previa also will quickly do, and then we'll see some MCQs, guys. So this is painless or painful bleeding, guys. It is painless vaginal bleeding. Here the fetus is good. There's no fetal distress or anything. On examination, patient will be in stable. Uterus will be equal to period of amenorrhea. Pallor also will be proportion to the bleeding itself. Uterus will be relaxed. As there is little space is compromised, malpresentations are frequent. Malpresentations will be frequent. There's one sign which you observe here. What is that sign, guys? There is one sign which you observe here. What is that sign called as? So that is Stahlworthy sign. Stahlworthy sign. So Stahlworthy sign is when you push the presenting part into the pelvis, the presenting part compresses the placenta and decreases the fetal heart rate. So Stahlworthy sign is decrease in the fetal heart rate on pushing the presenting part into the pelvis. So you should not do PV or pervaginal or perspeculum examination here. No PV and perspeculum. Investigation of choice is again USG, guys. Investigation of choice is again USG. Treatment, you can do expectant or McAfee regimen. So when do you do McAfee and Johnson's regimen is when gestational age is less than 37 weeks. Mother should be hemodynamically stable. And there should be no fetal distress. There should be no fetal distress. So when it fulfills all these three, then you can do the expectant or McAfee and Johnson's regimen. When it fulfills all these three, then you can do expectant or McAfee and Johnson's regimen, right? And here, what do? You admit the patient, you give a bed rest, steroids for lung maturity of the fetus. Tocolysis you give only if it is required. Otherwise, you don't give tocolysis. Okay. And when they cross beyond 37 weeks, then you can go for delivery. When they cross beyond 37 weeks, you can go for delivery. So beyond 37 weeks, for placenta low lying, you can conduct vaginal delivery. And if it is placenta previa, you have to go for elective LSCS. If I have to be precise, for type 1 and type 2A vaginal delivery, type 2B, 3 and 4, it is placenta previa. So this is a short and sweet discussion about the placenta previa and abruption. I tried to minimize and I hope you all understood it. So we will see now some MCQs, guys. Okay. A lady with 37 weeks pregnancy presented with bleeding per vaginum. Investigation shows severe degree of placenta previa. The treatment is Very good, excellent. So here the answer will be immediate cesarean section. Why you will go for immediate cesarean section? Because she has come to you with severe degree of placenta previa. So severe degree of placenta previa means total placenta previa or type 4 placenta previa, right? And that is not what why I'm doing immediate cesarean. I'm doing because she has crossed 37 weeks. So I have not, there's no point in waiting on her, right? So that is why you have to go for immediate cesarean section, right? Now, if in the same question, if in the same question I change it into 35 weeks, then what will be your answer? A lady with 35 weeks pregnancy presented with bleeding per vaginum. Investigation shows severe degree placenta previa. What is the management which you would like to do for her? So what will be the answer now? So 35 weeks. So as she has not crossed 37 weeks, it's only severe degree, but she has just presented with bleeding, but there's no, mother is not hemodynamically unstable or any fetal distress. So as they didn't mention that mother is hemodynamically unstable or fetal distress, I would like to wait on her if she presents to me before 37 weeks. Yes, even total placenta previa or class 4 placenta previa, you can wait, right? So if she presents to me before 37 weeks with the same case scenario, I will go for expectant management. So then my answer will go for C, conservative management. Very good, excellent. So then you will go for conservative. Correct. Understood now? So depending on the gestational age, your answer might change. Now let me change this question furthermore. See, this is the most important, guys. If you understand the concept, however they change the question, you will be able to answer it well. So understanding the concepts is most important while you practice. So let me change this question little more. A lady with 35 weeks of pregnancy presented with bleeding per vaginum with blood pressure of 80/60. Investigation shows severe degree of placenta previa. Now what will be your answer? So now, is she hemodynamically stable? Is she hemodynamically stable? So blood pressure has gone to 80/60. So she is hemodynamically not stable. So as she is hemodynamically not stable, although she is less than 37 weeks, I will go for immediate C-section. Very good. Excellent. Kaustubh and Sai Ramya. Correct. So depending on each case scenario, your answer might change. Depending on your case scenario, your answer will change. Okay? Good. Perfect. Regimen followed in expectant management of placenta previa is regimen followed in expectant management of placenta previa is yes. So that is McAfee and Johnson's. Where do we do Brand's Andrew method, guys? Where do we do Brand's Andrew method? Where do we do Brand's Andrew method? So Brand's Andrew method is done in third stage for active management of third stage of labor. It is done in third stage for active management of third stage of labor, right? All are true about placenta previa except bright red blood loss, painless vaginal bleeding, increased uterine tone, malpresentations frequent. So in placenta previa, yes, we have bright red blood loss. It is painless vaginal bleeding. There is increased uterine tone. Malpresentations, there is increased uterine tone in placenta previa? No. Uterus is relaxed in placenta previa. Uterus is relaxed in placenta previa. Malpresentations are frequent? Yes, malpresentations are frequent in placenta previa. Right? So C is the answer. Very good, excellent. Next question. A 21-year-old primigravida is admitted at 39 weeks of gestation with painless antepartum hemorrhage. A 21-year-old primigravida is admitted at 39 weeks gestation with painless antepartum. So when somebody tells it is painless, then immediately immediately you know that we are dealing with placenta previa, right? On examination, uterus is soft, non-tender, head is engaged. The management for her would be, so placenta previa at 39 weeks. When patient is stable, do you want to give a blood transfusion and sedative? No, right? So no. And 39 weeks, beyond 37, I would like to go for elective LSCS because I don't want her to go into labor and cause bleeding and all. So no tocolysis and sedative. I want to deliver her. But I don't have an option of delivery. Very good. Here the answer is C. So we don't do speculum examination also. But we can do pelvic examination in OT to confirm that this is a placenta previa. Ideally, you should not do speculum or pelvic examination. But you can do pelvic examination in OT with anesthetist, everything ready. And that is called as double setup examination. That is called as double setup examination. So you can do pelvic examination in OT and that is called as double setup examination. Okay. Next question. Savita is 32 weeks pregnant, presents in casualty and diagnosed as a case of antepartum hemorrhage. Vitals are unstable with blood pressure of 80-60. Which of the following is the next step in the management? So Savita is 32 weeks, diagnosed as a case of antepartum hemorrhage. Vitals are unstable with blood pressure of 80-60. Which of the following is the next step in the management? Okay, so I see all of you answering D. First and foremost, what do you think might be the reason for antepartum hemorrhage here? 32 weeks APH with vitals unstable. What do you think might be the reason? Is it abruption or is it placenta previa? Can't tell based on the question, but yes, as vitals are unstable, more likely to be abruption. Right, anyway, when patient is unstable and blood pressure is 80-60, will you go for immediate cesarean or will you go for blood transfusion, guys? आपको बच्चे को सेव करना है या मदर को स्टेबल करना है फर्स्ट? When mother is unstable with blood pressure of 80-50, 80-60, what do you want to do first? Do you want to transfuse blood to her first or would you like to go for immediate cesarean? They're asking you what is the next step. I would like to first transfuse blood in her. Then I'll go for, once she becomes stable, then I'll go for cesarean or whatever drama I want to do. See, they're asking you what is the next step. When patient is not stable, your first step is to stabilize the patient. Then only you will go for the mode of delivery. So you have to first stabilize her. So you are going to go for blood transfusion. Yes. So like in movie scenarios, you will not tell बच्चे को या माँ को एक को ही बचा सकते हैं, किसको बचाना है. No, yeah, you have to बचा for माँ only, right? So first go for blood transfusion and stabilize the mother. Commonly used grading for abruptio placenta is. So this just now we discussed what is the commonly used grading for abruption. So it is the page grading. You also have share grading, shares grading, but commonly used is page grading. Okay. Right. Now next guys, we'll go back to the first question which has come to you in your previous year question paper. Yes. So this has come to you in your FMGE 2020 exam paper. A 36 weeks pregnant patient has come to you with the complaints of bleeding per vaginum associated with pain. So it is associated with pain. The fetal heart rate is absent. Uterus is tender. What is the diagnosis and management? What is the diagnosis and management? So abruption and vaginal delivery, abruption and cesarean section, placenta previa and vaginal delivery, placenta previa and cesarean section. First and foremost, what is the diagnosis here? Is it abruption or is it placenta previa? So as she has come to you with painful vaginal bleeding and tender uterus, this is a case of abruption. Fetal heart rate is absent. It's a dead fetus. So do you want to go for cesarean section or vaginal delivery? So yes, it's an abruption with a dead fetus. So remember the table which I have taught you. So when you have a dead fetus, you can go for vaginal delivery. You can go for vaginal delivery. So you all are absolutely correct in answering placental abruption and vaginal delivery. Right? So I hope you all understood the abruption and placenta previa. And any doubts in abruption and placenta previa, guys? Right. So you can tell me what is the next topic which you want to learn or which you want me to present to you, which you want me to do as an online live session so that you will be beneficial to you. And any doubts also you can push forward. I'll be taking those doubts now. What is the next topic which you want to listen in the session? Any particular topic which you think I should speak or I should do a live session, feel free to message, feel free to. So dead fetus always delivered by vaginal delivery except in transverse lie. So it depends on a case scenario again. If you have dead fetus with placenta previa, then what will be the mode of delivery? So I can't tell that dead fetus always vaginal delivery. If you have dead fetus with placenta previa, then what will be the mode of delivery? Will you go for vaginal delivery or will you go for cesarean section? Okay, Kaustubh, I'll try to plan a session on malpresentation and I'll be coming live again. So when you have a dead fetus with placenta previa, you will go for cesarean, not vaginal. Why? I'm not bothered about the baby here, but when I conduct a vaginal delivery, placenta will come out first, followed by baby. That's fine. But what about the placental sinusoids? As the placenta comes out first, the placental sinusoids will be open and they'll go on bleeding till the baby delivers. So it can lead to the death of the mother only because of the continuous and excess bleeding. So dead fetus with placenta previa, you'll go for cesarean section. Even when you have dead fetus with obstructed labor, or even when you have dead fetus with uh, contracted pelvis or CPD, what will be the mode of delivery in all these? Will you go for vaginal delivery or will you go for cesarean section? So when you have a dead fetus with obstructed labor, CPD and contracted pelvis, what will be the mode of delivery? Will you go for cesarean or will you go for vaginal delivery? You'll again go for cesarean section because here, although baby is dead, the baby can't come out. So again, you'll go for cesarean section, right? Okay, any other doubts, guys? So I have a message here from Kaustubh that you want me to do a session on malpresentations. Yes. So malpresentations, the most common malpresentation is breech. So I'll try to put some MCQs on breech, transverse lie, oblique. Okay. So all the best, guys. Keep studying. Obstetrics and gynecology is a very easy subject and it is a highly scoring subject, guys. You definitely get almost 25 to 30 questions. And your main motto should be like, you should get those 25 marks from obstetrics. So, if you get the 25 marks from obstetrics, you have to get another 125 marks itself. So, try to be perfect with obstetrics. Try to make obstetrics as a very strong subject so that you can get your perfect 25 score. Okay. Thank you so much, guys. Good night, sweet dreams. I'll see you all in the next session. Thank you.